In this video, we will go through the GI secretory and regulatory physiology. Let's begin with what we see in the stomach. Now, very quickly, the stomach is broken down into various anatomical regions. We have the cardia, the corpus, sometimes referred to as the body, and the antrum. Now, within the corpus, the first that we're going to talk about are parietal cells. This is an epithelial cell with HK ATPase activity. The big thing to know about the parietal cell is that it secretes two main secretory products. One, hydrochloric acid, sometimes referred to as gastric acid, and two, intrinsic factor. Let's first discuss hydrochloric acid. So hydrochloric acid generates a strongly acidic environment for the gastric lumen, and that has three main functions. One, it kills food-derived bacteria, so pathogens just cannot survive in that very low pH environment. Two, it helps with digestion because that low pH environment, you can sort of think of it as melting down things that need to be digested. And then three, it promotes the absorption of various items including phosphate, calcium, and iron. The release of hydrochloric acid is stimulated by the vagus nerve, it's stimulated by gastrin, and it's stimulated by histamine. And it's inhibited by GIP prostaglandins, secretin, somatostatin, and cholecystokinin. And we're going to talk about all of these things individually, but just know that big picture, they all inhibit gastric acid secretion. Now, the way that I think about this is that VGN makes very great HCl. VGN for the vagus nerve, very great HCl. And this kind of helps you remember that the vagus nerve, which is acted through acetylcholine, is really responsible for stimulating the production of that gastric or hydrochloric acid. In other words, the vagal nerve is directly responsible for digestion. Now, intrinsic factor, on the other hand, binds to vitamin B12 to promote its absorption at the terminal ileum. This is really, really high yield to know that not only is it helping B12 get absorbed, but that the specific location is at the terminal ileum. And I'm not going to get into the details, but understand that if the terminal ileum is messed up through some other means that has nothing to do with the inherent intrinsic factor itself, then you can also get pernicious anemia, which we're about to talk about in just a second. So pernicious anemia is when autoimmune destruction occurs. And what you see are three main symptoms. You see reversible dementia, megaloblastic anemia, and subacute combined degeneration. So let's go through these things. For reversible dementia, pretty obvious. In the vignette, you will have a patient who simply appears as though they have dementia, right? They're losing their keys, they're wandering, they're not really acting themselves. Megaloblastic anemia, you're going to want to look at the lab printout that the test writer gives you. And specifically, you're going to look at the complete blood count and a peripheral smear, which they may or may not give you. They'll definitely give you the complete blood count. And what you'll see on these two items, if the test writer gives it to you, is hypersegmented neutrophils and megalocytes. You'll see a decreased serum B12 level, and you'll see an increased level of both homocysteine and MMA. And that's really important because you need to parse out what the homocysteine and MMA is doing to determine whether or not this is due to a B12 deficiency. You'll also see a low hemoglobin level, and you want to pay particular attention to the MCV, the mean corpuscular volume, and that's going to be elevated. It will be over 100 if it's B12 deficiency. So reversible dementia, and then all of these various things which you would see on the CBC or the peripheral smear. And then lastly, the test writer could give you subacute combined degeneration. And basically this is due to problems with the dorsal columns, the lateral corticospinal tract, and the spinocerebellar tract. Because each of these three tracts are impacted, you'll see a patient in your vignette with decreased vibratory sensation or decreased proprioceptive abilities. They will be weak, hyperreflexic, and spastic, and they'll be ataxic with a positive Romberg sign. So if you see this in combination with dementia, in combination with some of the findings we talked about for item number 2 on the CBC and the peripheral smear, you really want to start to think about, okay, there's clearly a problem with B12 here. And then they could tie that back to either a problem mechanically or anatomically at the terminal ileum, or it could be a problem with intrinsic factor specifically, in which case we're talking about pernicious anemia. So that's intrinsic factor. Takeaway here, again, the parietal cell makes both the HCl, which is there for digestion and immunity, and intrinsic factor, which is there to help B12 get absorbed. Now let's talk about the chief cells. Chief cells secrete pepsin. Pepsin really is derived from a prohormone called pepsinogen. So pepsinogen gets turned into pepsin in the presence of a low pH environment. So that is to say that pepsin essentially relies on the hydrochloric acid, which is coming from the parietal cell. So that parietal cell makes the gastric acid. The gastric acid creates this really nice low pH environment. And then only in that low pH environment will this prohormone pepsinogen get converted to pepsin. And then, of course, once pepsin is activated, we have optimal protein digestion. So that's pepsin that comes from a chief cell. Now let's talk about the G cells. And you can see here the G cells are located typically in the antrum. G cell, as the name kind of helps you remember, secretes gastrin. Now, gastrin promotes gastric acid secretion. So as you can kind of see, the big picture here is that all of these different things that get secreted in various parts of the stomach are acting on one another to help one another not only become secreted themselves, but also carry out their physiological function. So gastrin acts on the enterochromaffin-like cells, which creates histamine, which acts on the parietal cell, which makes gastric acid. So gastrin causes the downstream release of gastric acid, and then as we just talked about, that gastric acid is instrumental in its ability to help pepsin carry out its function in terms of protein digestion. So gastrin equals gastric acid, downstream as you can see here, and then gastric acid has all of these other activities. Gastrin, in addition to causing the release of gastric acid, also increases gastric motility, and it supports the proliferation of the gastric mucosa. Now, gastrin is stimulated by the vagus nerve, it's stimulated by a high pH environment, and it's stimulated by stomach distension. Now, this should make sense because in a high pH environment, the stomach is essentially sensing, okay, I need to get my pH into that low pH environment, which I can only do through the production of gastric acid. And so if you have that high pH environment that stimulates the release of gastrin, which as you see under item number 1 there, downstream will create the gastric acid that then makes the pH low. Now the opposite is also true because gastrin is inhibited by both somatostatin and decreased pH. That should make sense. When pH levels are low, the stomach has no reason to stimulate or release gastrin because we don't need gastric acid. Therefore, in that low pH environment, gastrin will be inhibited, gastric acid will never be produced because we already have that low pH environment. Somatostatin we'll talk a little bit about later on in this video, but the key takeaway that I'll just plant in your brain now is that somatostatin is essentially an inhibitor of everything. So if you see it, you can guess that it's inhibiting on your exam. So that's gastrin, which comes from the G cell. Big takeaway, gastrin equals gastric acid, okay? So gastrin is the upstream item which causes the release of gastric acid. Okay, so now let's talk about histamine. So histamine is secreted from enterochromaffin-like cells. Histamine is released from those enterochromaffin cells, which diffuses to the parietal cells nearby to increase hydrochloric acid. And so you can see I put the same exact flow chart or same exact image under that first bullet here because both gastrin and histamine are in the same cascade. They're both going to lead to the ultimate release of gastric acid. Histamine is stimulated by gastrin, which you should already know if you were paying attention on the previous slide when we talked about gastrin. And like everything else, big theme here, it's inhibited by somatostatin. So that's really all you need to know about histamine, that it comes from the enterochromaffin cells and that it leads to the downstream production of gastric acid. Now we will talk about the PD1 cells. PD1 cells secrete ghrelin. Ghrelin acts on the neuroendocrine system, and it has a couple actions that you need to know. In the lateral hypothalamus, it increases hunger. In the arcuate nucleus of the hypothalamus, it increases neuropeptide Y. And in the anterior pituitary, it increases growth hormone. Now, ghrelin is stimulated by fasting and sleep deprivation, so that should make sense. Because it causes hunger, it will be stimulated when the body is fasting. Okay? And because it causes the release of growth hormone, it'll be stimulated by sleep deprivation. And it's inhibited by stomach distension. So if the stomach is distended, or that is to say the stomach is full of stuff already, there's no reason to have ghrelin make us more hungry because we don't need to, cram more food into an already distended stomach. So that's ghrelin. Now, the way that I want you to memorize this is with my handy mnemonic, and I'm going to just capitalize a few letters here: G, H, and N. G for growth hormone, H for hunger, and N for neuropeptide Y. These are helping you remember the various things that ghrelin causes, right? Causes the release of growth hormone, causes hunger, and causes the release of neuropeptide Y, all, of course, in various areas of the neuroendocrine system. All right, so here is everything that we've talked about thus far. These are the various secretory and regulatory products that get secreted in the stomach specifically. And here is a table for your studying pleasure that very simply and very quickly summarizes what we've talked about thus far. Now let's move on to the secretory and regulatory products of the intestine. And we'll begin with the eye cell. The eye cell secretes cholecystokinin, also known as CCK. So this comes from the cells which are in the duodenum and the jejunum. And it has various actions. One, it causes contraction of the gallbladder. Two, it relaxes the sphincter of Oddi. Three, it causes the secretion of pancreatic digestive enzymes. And four, it reduces gastric emptying. Now you can see my mnemonic in the bottom right-hand corner of this slide. CCK contracts and causes kickoff. So what does this help us memorize? Contracts to tell you that it causes contraction of the gallbladder. And causes kickoff essentially means that CCK starts the process in the duodenal area whereby you break things down and absorb them. And so this should make sense. Look, CCK is stimulated by fatty acids and amino acids. In other words, when fatty acids and amino acids are present in the beginning of the small intestine, you're going to need contraction of the gallbladder, relaxation of the sphincter of Oddi, and then secretion of pancreatic enzymes through that sphincter of Oddi to attack and break down fatty acids, amino acids, etc. So that's why fatty acids and amino acids stimulate the release of CCK, which then causes pancreas to do its job and gallbladder to do its job. Additionally, CCK is going to reduce gastric emptying, which we would want to do if we're ready to transition from that mechanical digestion that occurs in the stomach to the breakdown and absorption which occurs in the small intestine. And this makes sense if you look at what inhibits CCK. CCK is inhibited by somatostatin, which again, big theme, it inhibits everything, and also fasting. Again, we're transitioning from mechanical breakdown of the stomach to breakdown and absorption in the small intestine. So we contract and cause kickoff. That's CCK. Now let's talk about the D cells. The D cells secrete somatostatin, which to this point in the video has pretty much inhibited everything. So let's take a closer look at somatostatin. It's secreted in the jejunum and also in the pancreas. And what does it inhibit? It inhibits GI secretions. It inhibits the contraction of the gallbladder. It decreases GI motility in general. So it basically is an off switch to everything that we've talked about. It causes splanchnic vasoconstriction, which you should think about. When you hear vasoconstriction, you should think decreased activity. And when you hear vasodilation, you should think about increased activity because it's all about blood flow and nutrients getting to local regions. So if there's splanchnic vasoconstriction, it means we don't need to send blood to these organs in these areas because they're not doing anything. So somatostatin causes decreased blood flow because we're turning everything off. And lastly, it inhibits growth hormone and TSH secretion, which you would need in order to grow and make use of all of the various fuels that we've talked about. Somatostatin is stimulated by gastric acid. It's stimulated by fatty acids and amino acids in the intestine because somatostatin is going to turn everything off. And so if you have all of the fuel that you need and you're absorbing it, you're getting ready to turn it all off. And so somatostatin is being released. Likewise, it's inhibited by the vagus nerve. So when you're ready to turn everything off, you're going to get increased vagal activity, and that's going to release somatostatin and turn everything off. Now let's take a look at item number 1 here. When I say that it inhibits GI secretions, I'm talking specifically about HCl, aka gastric acid, gastrin, pepsinogen, CCK, secretin, VIP, glucagon, and insulin. Again, it's turning off everything. And so the way that I think about somatostatin is I think of no matostatin, like Michael Scott yelling, "No! No!" That's somatostatin. It's no. You get none of it. It's all turned off. All right? So that comes from the D cell. Now let's talk about the S cell. The S cell is going to secrete secretin. And secretin is secreted in the duodenum. And this is going to increase bile secretion. It's going to increase pancreatic bicarbonate secretion. And that's important because without pancreatic bicarb, the other pancreatic enzymes don't work. So it's very important that you secrete those or that secretin does its job if we're going to go through this digestive process. And then lastly, it decreases gastric acid secretion. So when secretin comes out, the stomach is sort of being turned off. So you're decreasing gastric acid secretion. Secretin is stimulated by gastric acid and fatty acids, specifically in the intestine, and it's inhibited by somatostatin. So you already know what it's inhibited by because somatostatin inhibits everything. As far as it being stimulated by gastric acids and fatty acids in the intestine, well, if you have stuff in the intestine, secretin wants to break that stuff down, so it causes, bile release and pancreatic bicarb release, but it's decreasing gastric acid secretion because, again, secretin is recognizing that we're transitioning from mechanical digestion, which occurs in the stomach, to more of a chemical digestion and absorption, which occurs in the intestine. That is secretin. Now we have the K cell. The K cell secretes gastric inhibitory polypeptide, or GIP for short. GIP is secreted in the duodenum. It increases insulin secretion, and it decreases gastric acid secretion. So GIP is stimulated by glucose, amino acids, fatty acids, all in the intestine. And that should make sense because since GIP causes the increase of insulin release, it's going to be stimulated by glucose. And likewise, because GIP is inhibited by fasting, it should make sense to you that in the presence of glucose, we're releasing insulin, but you don't want to release insulin when you're fasting. That would be problematic. It would cause hypoglycemia. So therefore, GIP is inhibited by fasting. The way I want you to memorize this is GIP gets insulin popping. So GIP causes the release of insulin. That's very important. Please know that for exams. Now let's move on and talk about the parasympathetic ganglia, which secretes vasoactive intestinal peptide, or VIP. VIP is very important, as the name does not imply, but as I like to joke, because it's secreted in the small intestine and it causes the increase of water and electrolyte secretion, and it causes smooth muscle relaxation. Now the name V in the name stands for vasoactive. So it shouldn't surprise you that the one thing here with vasoactive in the name is vasoactive, right? It increases water and electrolyte secretion, and it causes smooth muscle relaxation. That is definitionally what vasoactive means, so it's kind of easy to memorize. VIP is stimulated by GI distension and parasympathetic tone, and it's inhibited by sympathetic tone. Not a whole lot to know here. Vasoactive is the only one that's vasoactive. So if you see water, electrolytes, and smooth muscle relaxation, think vasoactive, think VIP. One little caveat here is that there's something else which we'll talk about at the end that also does smooth muscle relaxation. So more on that in just a moment. Mo cells secrete motilin. Easy to remember because mo equals motilin. And motilin sounds like exactly what it does. It causes motility. So this creates migratory motor complexes. You don't really need to know that name, but I put it here for completeness sake. And what that does is it increases intestinal motility. So the Mo cell secretes motilin, which causes motility. Easy to memorize. It does exactly what it sounds like it does. The one thing I want to point out here is that you have motilin receptors, and certain medications, like the antibiotic erythromycin, is actually a motilin receptor agonist. So certain medications will sit and agonize those receptors, and that does the same thing that motilin does. So the Mo cell secretes motilin, which causes motility, and motilin receptor agonists cause intestinal motility. So that's why erythromycin can be used to stimulate intestinal peristalsis. The only thing to know here is that it's stimulated by fasting. So when you're fasting, you want intestinal motility because we're going to prepare to move things through the system and get ready to, absorb, break down, digest, etc. We're going to conclude by talking about the smooth muscle cell, which secretes nitric oxide. The big thing to know about nitric oxide, and I put a warning 2 slides ago, is that it's secreted by smooth muscle cells, and it causes relaxation of smooth muscle and sphincters and vasodilation. So it kind of does what vasoactive intestinal peptide does, but it's a bit unique in that it primarily targets smooth muscle relaxation and vasodilation without the water and electrolyte stuff that VIP did. So with nitric oxide, I always think of NO, like the O expanding and getting bigger, which is like the lumen in my brain. It's the lumen of some type of smooth muscle that just dilates and gets bigger and relaxes. Same thing for a vein or an artery, smooth muscle, whatever you want. It's a lumen, that O in NO, it's just getting bigger because it's relaxing and vasodilating. And that's always how I've memorized the action of NO, or nitric oxide. So here is your summary slide. It's a little chart that summarizes everything in a very bare bones way. I know that I went through that very quickly, but the more that you can do it in the way that I just did it, the more comfortable you'll be with this material. Because I know that when you look at a giant table in your review book or your QBank, whatever it is that you're using, it's incredibly overwhelming. But if you break it down to its bare bones and just keep it stupid and simple, that's when it's easy to memorize, and that's when it'll be easy to answer the questions on test day. Best of luck.